All right, officially, good morning. I appreciate you coming. The entrance and exit is difficult here, but we'll have plenty of food. One of my strong advices is please speak up, ask questions. That's what you're here for. We're not here to lecture. We're here to help each other teach and learn. I do want every one of you to go to each booth for about 5 minutes, if you can, to see every machine and then free bubble makers. So if you haven't done that ever, please do it. At this meeting, it's a personal meeting, so you can actually get to know the equipment, the manufacturers, and the application specialists. Please, thank you. So conflicts, we go through these. All the program was reviewed by a conflict group, and if there's a conflict, we then disclose it to you so we don't bias our presentation. Forms. We have a bunch of very interesting forms. These are the billing code forms. They're going to be in the refreshment area by the machines. So these will give you the exact numbers for billing. This is our ICUS information. Please join ICUS if you haven't. I hope everyone here has, and I'll go through that a little bit. And then here's the recommendation ICUS put out for sonographers starting IVs. So I guess I should back up and say, if you're not an ICUS member, please join. We'll go through that. It's free. You get newsletters, but it's the International Contrast Ultrasound Society. It's ICUS-society.org. We'll cover that more, but what we do is we create an international society supporting the safe use of ultrasound contrast, and we've been to the FDA 9 times to change their view of contrast, and we've been to CMS so we can get reimbursed. So this one sheet, I think, is very important. It's the ICUS cheat sheet on how to bill for your procedures. Good. And it's nice to have students here, too. I'll say, here's the Wi-Fi connections. Basically, just get on as visitor, and then the password is quality. And please, if any of you are tweeting, please follow us at ICUS_society. Thank you. This is the address that you sign up on the web for membership. And when you get this, we have a very active website. There's a lot of educational materials, particularly for you students too, on the website. Please use it. And as I say, membership has been free. We want to thank everyone for coming, and we have people live streaming this. We want to thank Live Media, who has been with us for years, and at the Bubble course as well. And the faculty, yesterday we had a course for general imaging, and Stephanie Wilson, Richard Barr are some of the world's experts in this area, really talented people. Today will be in cardiovascular, which includes cardiac and carotid imaging. Tom Porter will join us, and Joey and Jessica will be lecturing on how to set up an echo lab. So we'll have people drifting in over the course of the day. And thank you very much for the people at Denton's who support this. Diana is sort of the manager here who runs the place, and we're very pleased to have her here. And a long list of excellent support systems. And thank you for coming. So let's get started. The International Contrast Ultrasound Society, why did we create this? This happened, as you might know, in 2007, if some of you were born by then. It was in a response to the FDA. The FDA had said, oh, let's put a black box, which is a severe warning on the use of ultrasound contrast agents. So we went around to different organizations in this country and said, look, we're bubble people. Will you help support us? And yes, everyone was supportive of us, but nobody was really dedicated to bubbles alone. And we think bubbles are very valuable in saving lives and improving care. And I'll go through some of that today. So that's why it was created. Now it's become a much larger organization, some 60 countries, thousands of members, and dedicated to us, sonographers, physicians, nurses, doing contrast ultrasound. And it has changed lives. So as we begin, after the Chicago fire, Daniel Burnham was reported to have said, make no little plans. They have no magic to stir men's blood. That is, don't do anything a little bit. Do it well or not at all. And this is a testament to that. You're here. It's a beautiful Sunday. and we're studying contrast ultrasound. All right. Is our field going to grow? Definitely. These are some data from 2016 that things that will carry us forward for years will be handheld units, 3D contrast, 3D alone, 4D. These are things that we're here to learn. All the machines that you have here do 3D, both TEE and transthoracic. All the machines do contrast. That's where we're going. What's the market growth look like? Big. So as you can see, you're in a good field. It will continue to be a good field. Oh, no. Oh, no. You don't get that answer yet. All right. How many transthoracic echoes did we do only in the USA last 2016? I can tell you 2017. But in 2016, how many transthoracic echoes did we do in the USA? Inpatient, outpatient, doesn't matter. Hands, comments, yes, yell out.
1 million.
1 million. We're in an auction here. 1 million going once. Well, you know what, folks? That's not even close.
No.
No, you're not close. I'm sorry. 32 million. Yeah, that's one for every 10 people in this country. Okay? Hey, Tom. Good to see you. So, folks, we're doing 32 million echoes in 2016. In 2017, we did 34 million. It's going up about 6% a year. So your jobs are secure. Should I say that? And this is the sort of growth rate we've seen. You would think it would plateau out. No, it's not. It's continuing to grow. Honestly, we're looking somewhere around 33 million echoes a year coming up. And here's an interesting statistic. Most of us, I would say, do see older patients, correct? That's the majority. Medicare patients over 65, 70. Look at the number of patients in that age group who will have an echo that year. Roughly 25% of people over 75 will have an echo. So those are going to be repeat patients. Now, having said that, as part of this introduction, sort of to get you geared up for you're in a good spot at a good time, and there's new things for us to learn, are we doing too many echoes? Because, of course, when the government sees that kind of number, they say, wow, 1 in 10 people in this country are getting an echo. So a nice paper came out in 2016, and it said, let's survey. Are we doing too many echoes? And I think what you would hear is, yeah, but the answer is no. It's actually underused. And where is it underused? Where we need it most. In the acute care settings, we're not doing the echoes. Where are we doing them? In the outpatient, valve disease, etc. So it's counterintuitive that one would say we're doing too many. No, we're doing them in the wrong places. No, we're doing them in the right places for valves, but we need to do more in the critical care setting. Those are some of the toughest echoes. Those are the most important. Those are life-saving echoes. So why are we here talking about that with echo? Because of contrast. And we'll get to that in a bit too. And why are we doing echoes to begin with? This is a report from the Advisory Committee, the American Heart Association, Cardiac Imaging, Council of Clinical Cardiology, Cardiovascular Intervention. We're using a little too much radiation. I would say on a weekend when you have a young person, a young lady, let's say 40, coming in to the ER, and she has chest pain, a quick test will be a SPECT, or a nuclear imaging. Am I correct? Does anyone here do stress echoes on the weekend? Please raise your hand. 1, 2, 3, 4, 5. All right, you do. That's how many do nuclear imaging on the weekend? Everybody, probably. Okay. Good for you for doing stress echoes on the weekend because many places don't. I'm not going to comment about my institution. But a SPECT study has roughly 3 times the radiation of a cardiac catheterization. Nobody knows that. We don't talk about it. So when you're asking your patients to get a stress echo, fine, we don't have radiation. If you're going to get a SPECT study, you will. Now that is not discussed. And for someone who's 42 years old or 50, a woman, you might want to talk about that. So this report came out in 2009, I believe, and it said, look at physicians should emphasize imaging exposed patients to radiation, and you should be thoughtful about it. So kudos to you doing stress echoes on the weekend. In addition, what about children? Well, this is an interesting study, again from 2010 from the Wall Street Journal. Look at it says up then down. Really, look at younger than 5 right here. On this group, they're still getting 15 CAT scans per 1,000 children. Those things should be discussed. If they're critical to use a CAT scan, then do so. But if not, not. And are we in a good spot, everybody? Yes, we are. The green line is us. Going up, that's non-invasive imaging. And the red line is relatively flat, that's interventional imaging. Good. So, back to us. It's our time, ultrasound time. Why? Well, there's safety concerns. We know that. There's institutional medicine. I think you all know that as the hospitals absorb more and more centers, there's one protocol for everybody. And we do it one style. And there's central reading, which is good to some degree. But there should still be some independence on choice of equipment, choice of agents, use of contrast, protocols. The mothership can't control everything, but it should set some guidelines. So there's changes in institutional medicine. Healthcare reform just means do things wiser, cheaper, faster, and it'll be probably based on diagnosis rather than procedures, which is good for us. Contrast ultrasound is still alive and well. 3D ultrasound is a big push. We really have to look at that. And again, I would just ask you, make sure you look at every machine and ask about their 3D transthoracic probes too. And the final thing is, are we using too much big box imaging? Probably. It's necessary, but not all the time important. All right, so what is our big challenge, at least as I see it? Generally, we get a request to do an echo for one thing, ejection fraction. Yes, the valves are important and effusions are important, but generally it's heart function or left ventricular or right ventricular function. And as you know, we calculate ejection fraction by dividing the diastolic minus the systolic over the diastolic. All right, and these are some examples. We're looking at about 150 cc's in the whole chamber. So it's not a big object. All right, is that important to identify? Yeah. If you look at this chart, here's the ejection fraction on the bottom, so 70%. And as it gets lower, this is the mortality rate. So it is correlated to your survival. So it's important to give a reasonably good number to a patient. So we have digital cut points, as you well know. For example, if the ejection fraction is below 35%, we may require a defibrillator. And there's cost to that, and there's patient discomfort, and there's follow-up. So I could ask everybody in here, ejection fraction, are we all comfortable measuring it, eyeballing it? On people, not normals, anywhere from between 20 and 40%, are we pretty good at that? We'll just, all right. I'm taking it that everyone's not saying, yes, we're very comfortable. Is that right? We're kind of comfortable? If I put cases up, kind of. Okay. Now, kind of is a good number because it's kind of 35. Is it 40? Well, at 40, you probably don't get a defibrillator, right? And I think you all know that. So there are some issues we have to resolve yet. And that directly looks at contrast. Are we using contrast to help us do ejection fractions? And Tom Porter will get to that a little bit, and so will I. All right, what if the ejection fraction's below? Yes, Jim.
So, regarding your idea on LV volume, there's some recent literature saying that the LV volume is measured with contrast filters. Now, are you, do you have a position on that? Are you aware of it? What
Good question, Jim. I'm going to call on Tom Porter, too, University of Nebraska, Omaha. Oh, let me get the mic.
Yes, it seems to be, I'll show you some good examples of why this probably is true, is that we're much closer correlated with MRI when we use contrast-enhanced volumes, especially with very low MI imaging, very low mechanical index imaging, because we see the compacted border. So much better, and that's typically what MRI is detecting, and that seems to be why these volume measurements are correlated closely with non-contrast echo. A lot of times what we see as telemetering are compacted borders. And the same is true of regional wall motion. You'll miss regional wall motion MRIs for the same reason, is that non-compacted border will sometimes fool you into thinking that wall's moving normally when it's clearly severely hypokinetic and affecting the ejection fraction and altering your diagnosis. But volumes definitely are larger. You're exactly right.
I think as a reader, we have to be aware if we're looking at serial studies, one with contrast, one without. So that's going to be confusing.
Yes, the normal range will be different, and we emphasize that in the guidelines, although we don't know exactly the normal range for contrast enhanced images, but that range will be different. The ejection fraction is probably about the same, ironically, but the volumes turn out to be different.
I think that's something that many labs don't realize, or and it's something to keep in mind, though.
Now, we can just pause here for a second, because as we said, all of us want more of a discussion, educational meeting. That's why we're here, not a lecture style. And I don't want to drill the point too hard, but are we doing ejection fraction reasonably well? Comments? I know you perform them, people read them. Do you think your estimates are what other people see? Anybody? Questions? Jim?
At least in our lab, when we have a ejection fraction done by the nuclear group, inspect, it's usually significantly off what we get in the echo lab. So, have you guys seen that?
Yeah, and I think the reason for that is, the reason for that with nuclear is that they're doing 8 frames per cardiac cycle. So they could clearly be missing in diastole and systole, and a lot of that is processed data. We find that if we use a biplane, consistent biplane quantitative measurement, that if we're following a chemotherapy patient or trying to assess the need for defibrillator therapy, that seems to be the most helpful and most agreeable to your eyeball. Your eyeball still eventually kind of judges at the end of the day, but we usually use that biplane measurement if it's done properly, non-foreshortened images. That seems to have some fairly useful reproducibility and allow us to kind of follow these patients a lot better, more easy than strain or using MRI, for example. Now, MRI is probably the most reproducible, but the problem there is if you want to do that serially, it's an extremely expensive option to undertake. But with biplane contrast-enhanced echo, we find that to be fairly useful and easier for the sonographers to do. We have a lot of trouble reproducing strain.
Yeah, strain, and we can all discuss that as an option to EF, but I mean, honestly, EF is what we're called to do. I'm always embarrassed in the lab. We do often ejection fraction by committee. I will turn to my colleagues and say, what do you think? So, I mean, I'm open to a discussion. I'm sure we can have it at the break too. Tom is right. We do biplane, we do contrast, we do everything we can, but I will tell you on another day, another reader, good luck to you. And will 3D, auto 3D ejection fraction come along? I hope so. And is that going to be contrast enhanced? Yes. So what we really want is a volumetric analysis of the ventricle, not 2 planes. You know, 2 4-millimeter cuts of the heart don't quite cut it. What you want is a whole volume. So, guys, we're doing fine. I think we can do better, and we probably will do better. All right, let's move off of that. This is sort of beating a dead horse here. We need to get better at this. And remember, contrast was designed for LVEF, and that's really where we should focus our efforts. All right, so I think you know about the microspheres. They're acoustic microspheres. They are used for enhancing the images. We have the 3 manufacturers here. We have 5 machines, and all the machines are contrast compatible, thank goodness. And much of this is thanks to Tom Porter, many others who have been at this for a few years. This is a good example. I'm not sure how people can read on the left a true ejection fraction, yet it still goes on. And you know, our usage of contrast right now in this country is around 7% of all echoes, on that of 32 million in 2016. So is that all that need contrast, roughly 7%? Well, that's why we're all here. All right. So if we're going to do biplane, we need to find an edge to trace, and here we can trace it. Okay. Let me just show you one. One of our sonographers a number of years ago was near the pacemaker lab, and they said, "Gee, this is a terrible looking heart on the echo, but we're going to check the defibrillator." So she was called in, Kim was, and said, "Let me just take a quick look." Well, that was during the defibrillator check. You can see the wire on the left here. And then that's what she found. And the patient didn't know they had a big clot in the ventricle because the echo, if you look at it and you say, "Oh, it's okay, it's a bad heart," and just move on, right? That's, no, she didn't. So, and it's actually quite large and you can see the edges of it. So it's a very useful thing, even when you're not expecting to find something. All right, so is stress echo a good place for contrast? Of course it is. This is from Canada. It's from the Ontario Health Technology for the nation of Canada. And this is January 2010, only 9 years ago now. What did they say? They looked at a bunch of observational studies and they came up with these conclusions. Stress echo with contrast has a higher diagnostic accuracy in the diagnosis of coronary disease than without contrast. That's a nation stating this. Stress echo seems to have similar accuracy as technetium or SPEC, without the 12 to 13 millisieverts of radiation, I might add. And in addition to contrast, it helps suboptimal images and improves the ability to interpret the results, and there's no issues with safety. Safety. We've been, as I said, as a group, through ICUS to the FDA 9 times, continually questioning their reason for putting on a severe warning, or we call it a black box. 3 times that has been reduced, and now ICUS has a citizens petition before the FDA, supported by many organizations, asking that the final step remove even your warning on the black box out. Everything else has been removed, the shunts, the monitoring, the blood pressure, because it wasn't based in fact. So ICUS still has 1 petition left at the government, and when you join ICUS, you will get constant newsletters telling you what is going on with our efforts at the FDA. This is one of the slides that we used and many times at the FDA. So what this does, these are a series of studies of patients using contrast and not contrast. And does this favor experimental? That means the use of contrast. Yes, this favors no use of contrast. So if the safety falls where my little dots are, that means contrast is safer than not. Say, well, I don't believe that. Well, hold on, we'll provide some data. Who else has been supporting the use of contrast besides ICUS? Everybody. And most recently, the Chinese Ultrasound Doctors Association, CUDA. They have 170,000 doctors in China that do one thing, ultrasound. It's an amazing group. All right. Many years ago in 2009, this was a most remarkable study for those of you who still have pushback. And I'm assuming some of you here have labs that are not fully using contrast. Is that fair? For example, we use it nearly on every single stress echo. Does anybody here do that? Oh, all right. Okay. We use it about 40% of our patients, which I know you're going to say is high, but almost every intensive care unit patient gets treated with contrast routinely. Does anyone do that kind of number? Can I see hands? Tom? Jim? All right. Yeah, okay, thank you. Stroger too. That's come a long ways, guys. Do you remember, Tom, we used to be at meetings and like nobody used. I'm really happy to see that. Let me just go through this quickly then. 2009, here's the story. At Baylor, they took transthoracic patients in. They said, hey, if you have 2 out of 6 regions we can't see, you're getting contrast. But first, we're going to do the echo, call your doctor, give the results. If you qualify contrast, we're going to do the contrast, call your doctor back. What happened from the first echo to the second without and with contrast? Well, here's what happened. In the sickest patients, right in the middle, SICU and MICU on the sides, it dramatically changed either procedures that were not necessary or medication. I mean, can you imagine changing medications based on an echo with contrast? Yes. And you might say, gee, even in outpatients, yeah, 13% mattered. So it isn't just for the sick patients, it's for everybody. Things changed. And what did they find? This was one of the most remarkable. The bad images went from roughly 12% down to nothing. And here's an incredible one. Therapeutic decisions change 10% of the time. So you come into the hospital, we're going to change your medications due to a contrast echo. 1 in 10 people. And thrombus, this is frightening. LV thrombus was suspected in 35 patients, definitely in 3 before contrast. Call the doctor, hey, you may have a thrombus in your patient, and certainly 3. After contrast, 1 patient had a thrombus, but there are 5 new ones. And did it save money? The answer is yes, it does, because you don't need additional studies. Now, years ago, we say, well, we're going to do the echo, and if we really need it, we'll start the AV, call the physician, get an order. Oh, boy. That never really was a good workflow solution. We can talk about workflow as we talk more about other things. So anyway, it's moved along very nicely. Now, this was the clinical applications, and who's the main author of this? Dr. Porter. So he'll talk more about this. I love it. This is some of Tom's work. Look, at ultrasound enhancement should be used in all patients in whom quantitative assessment of LVEF is important for the prognosis. And I would just argue, isn't it important on everybody to give an EF? That's what they're coming for. So it's really nice to have Tom here supporting this, and this was published. If you haven't seen this, that gives you confidence to go ahead and use contrast for EF on a routine basis. Don't look at the graph. This one recently came out. It's from Seattle. It said contrast echo has the greatest impact in patients with reduced ejection fractions. Yeah, because that's where our therapies are, our defibrillators, our heart failure therapies. We don't need help when someone has an EF of 65, 70. We need it anywhere below 50. All right. This is the most important paper, probably in my lifetime, doing contrast. And honestly, it's Mike Main's group in Kansas City has just been stalwarts since the FDA decided there was a problem with contrast. As a group, we fought back. I don't think there's any prouder moment we have than supporting echo when we said contrast matters. It is cost effective, gives you the right diagnosis, critically ill patients. But folks, if you haven't seen this paper, this is from the Journal of American Cardiology 2013, acute mortality, critically ill patient undergoing echo with and without contrast. Now, you would be happy to say, oh, just if it was neutral, if it didn't affect things, just gave better images, that's pretty. And I can remember going to the FDA many years ago. Lynn Stevenson was on an FDA panel. She's an electrophysiologist, and she said, okay, that's really nice. You got pretty pictures with contrast. What does it matter? And that was in front of the panel, and it was said in sort of a demeaning way, like, good, you spend this time doing prettier pictures, so what? Well, a few years later, I'll tell you so what. In critically ill, propensity matched, hospitalized patients, millions, the use of contrast was associated with 28% lower mortality at 48 hours in comparison to patients who didn't get it. Now, how do you do something like that? So what they did is they went backwards, so it's retrospective, but they matched up the patients with, let's say, 3, 5, and 7 ICD-9 codes. Let's say heart attack, stroke, pneumonia. Okay, diabetes, heart failure. So 3 times 5 codes, 7 codes. If you look at the chart here, folks, every coding situation, where was there less death? It was here in the contrast group every single time. So this was millions of patients scanned backwards, propensity match, multi-center. It wasn't one center. And every time contrast was used, the patients lived longer. I can remember when we went to the FDA after 2008, when they warned us in 2007, Paul Grayborn stood up and said to the FDA, because you did this, you're going to kill patients. And that was, people thought, an outrageous statement. I would like them now to read that Paul was not only correct, he's now validated. So what you're doing matters, folks. And I just want to say one other thing. When you're doing these studies, and we use contrast, and we get pushback from anybody, administration, other colleagues, hurry up, do it faster. No, because that patient who's getting the study is 100% there at that time. We may have 10 studies to do the day, and I know we got to move through. But for that patient, they shouldn't get anything less than the best if there's any question, and it matters. So I would paste this on your door. If anyone ever pushes you back, say, here's why we do our job. And I would ask you to name another imaging modality that is so studied now that you can say to the public, if you use echo and the contrast in tough patients, patients will live longer. Tell me another modality that you can, where has it been documented? What data is there from MR, CT, and PET? Maybe there is, but certainly we have it. So you should feel very proud of your work. This is just a graph I kind of put in 2017. I think we're somewhere, Tom, I can't verify this, but it's been creeping up. We remember those years, 2007, 2008. Now, let's just flip back to non-contrast for a second, just echoes. Illinois is kind of right in the middle here for, do we do too many, too few? And we can go over to Nebraska. They're doing a lot. Nebraska's doing a lot more than us. And how about Wisconsin, where Jim's from? Well, Jim's a little bit below Illinois and below Nebraska.
I don't have privileges that everybody has.
Now, I'm from South Dakota. Thank God I'm not from North Dakota. I don't think they report data there. Anyway, the point here is what? It's crazy. Why isn't there a standard? When somebody needs an echo, why isn't that kind of a standard thing? All right, enough. What about contrast? Well, sure. Look, if there's variability in doing echoes, you know there's variability in doing contrast. Illinois is kind of in the middle. Look at Florida, 1.4%. This is 2014 data from Mike Main. Look at California, 1.7%. Good care? Okay. You know, I've been asked too, they say, well, the data you show about cost effectiveness, critically ill patients, saving lives, don't other people read that? Yeah, I think they do, but there's a difference between reading it and practicing it. And when you're in the lab saying, come on, we got to get 8 to 10 done for every sonographer a day, got to read 50 to 90 echoes a day. I don't know if that's really an okay answer. All right, what are the new things? Well, as you know, in 16, after roughly 30 years of waiting and now finally catching up to the rest of the world, our radiology colleagues, we had a nice meeting yesterday from radiology, they can use contrast for liver. Also, the shunt has been removed, so I don't want any more discussion about that. That's not a contraindication. And we have new CPT codes for myocardial perfusion, which Tom will talk about. And we can discuss how many are doing that. It's more of a skill, but that's why you're here today too. Now, one of the big things, and ICUS played a role in this along with other organizations, but an important one. The first time the FDA has approved bubble use for children was in 2016, and they didn't base it on clinical trials designed by the FDA. They based it on the literature. This has never been heard of before. And why? There was a lot of pressure from outside groups, I think, on the government to say, stop radiating children. Use ultrasound instead, and if you do, you can use contrast. So this is a remarkable step. Now, one more comment I'm going to make. I mentioned our billing sheets are out there for everybody. The ICUS billing sheets, please pick one of those up. Here's what's going on in radiology in a nutshell. You can use any bubble and any machine in any organ. Liver, kidney, carotids, go ahead, and you'll get paid because CMS will pay you at the rate they pay MR and CT. The difference is when CMS says, here's the CPT code, here's your money, the FDA does or does not have to approve it for that use. In this case, we are all in line here. We have FDA approval, we have CMS, we have reimbursement. Radiology's first step, CMS thought it was so important, they said, we're going to grant you a CPT code and reimbursement for any agent, any organ. The companies now, the 3 bubble companies, have to go to the FDA and say, oh, we already have reimbursement. Can we get approval? You don't need it. Okay. We don't need it as a physician. We can practice our skills and sonographers without the FDA approval because we have CMS approval. It's a kind of a difficult situation, but it put the FDA now kind of in a backward position. But it is the companies now that have to go to the FDA and say, look, we have reimbursement, we have CMS, we have people using contrast in radiology, why don't you just give us the approval? That's where we are with ICUS too. So it's called a whole body indication. Do we really need the FDA to put a stamp on it? We need the FDA to do that because the companies who manufacture the microbubbles cannot tell you you can use it for any organ, any agent, and get paid because they have to follow FDA guidelines. But I can tell you that, and CMS can tell you that. So anyway, they're following behind us a little bit, but radiology took a lot longer to get where we are. Okay, this is a beautiful one. This was published by the ICUS group, and Jeremy Parker was a fellow of mine. Just want to point out one thing. When you're using microaggregated albumin for lung scans, you know, when you do a pulmonary lung scan, those are large particles. If you read here, MAA, microaggregated albumin, you can't read this maybe, but they're 10 to 150 microns in size. What they do is when you inject them in the arm vein, they go to the lung and they get stuck there. They block capillaries, but they have technetium on them. So when you scan, you see a blockage because that's where the pulmonary embolism is. But they were giving us a bad problem about shunts for microbubbles that are up to maybe 10 microns that slip through capillaries when they're using macro aggregated albumin that absolutely shunts through your lung and gets stuck in your brain and kidneys. So we use some of these arguments back that lung scans were not even discussed by the government. So why are we being held to this higher standard, which made no sense? Anyway, that was a lot of the basis for turning that over. And then Casa Darje put out a paper with ICUS saying contrast ultrasound is safe in children. Now, both of these papers, the shunt paper and this paper, were requested by the FDA officials when we went there as an ICUS group to give what we call a professional society briefing. They basically said to us, oh, great, why don't you put out papers on this topic and we'll review it later. We did so, and they did so. It's a very nice relationship. So one more thing now, our core lab's gold. That is, when you send your data to a lab that's supposed to be the mothership and supposed to give all the information, variability related to imaging quality, biologic variation, and interpretive differences can limit the reliability of cardiographic results. That is, folks, you're not alone. These papers that come out and say, look, we are the core labs for a big international or intercity study, they're not so great either sometimes. So there was an editorial then, our Echo Core Labs gold standard or fool's gold. I'm just saying, and we talked about this a little, we have some work to do, all of us, on precision. Is AI going to help us? We'll see. But it just means do a good job, do the contrast, do your biplane, hopefully 3D, and we'll move along. So, summary, lots of echoes being done. Ejection fraction still a big game. I wish we were better standardized. We're not using contrast enough where we should. And are we going to move to automated ejection fractions potentially in the future? I hope so. Anyway, thank you very much. Let me stop here on this series and now open up for questions. Any questions? No. Yeah, sure. Thank you. Let's take just a little break here. I think I go right into the next one too. This is where I'd like you to join. Just if you can take 1 minute. If you're not a member, do so. www.iceus-society.org. And yes, when I'm up here lecturing, you can be on your handheld or your computer reading that instead of listening to me. That's fine. No offense. There's some beverages over here too. If you want to just take a quick break, I'll set up for the next lecture. I think I'm on time. Yeah. right, folks, no questions or comments? Nice to see you, Val. All right, team, let's move on to, oh, I'm sorry, Val. There's a microphone right in front of you, Val. Just turn it on. Is there, from ICUS, is there a manual on how to overcome stiff resistance to use contrast? Yeah. Yeah, well, you're talking about your administrative people, right? Yes. Well, bring Tom Porter over. Val, I don't know how to answer that. The literature we put out here, you can print out those, say, can we have a discussion? You know, contrast saves money, it's effective, it saves lives. Can we begin a program here? You will actually do better echoes and you won't send them back for returns. You won't do a TEE, you won't do a nuclear study. We won't turn away people who have bad images to another scan.
And the cost effectiveness, right?
It's right in those papers.
Those slides, your slides are available, right?
Thanks, Tom. Yeah, the slides should be available, Linda, on our website. Better speak up.
Will be live streamed now for CME credit, and after the program is over, all of the lectures will be available at no cost on the ICUS website. You can look at individual lectures or you can watch the entire program. There's never a charge for accessing any educational materials on the ICUS website. Because our goal is to educate, we hope we can do that.
And it's just, Val, it's just sitting down, having a calm discussion. Now, I will just take an aside note here too, and we all deal with P&T committees. Is that what you're talking about? Okay, is everybody here familiar with P&T committees? Pharmaceuticals and therapeutic, they're the pharmacy group in the hospital who decides what agent you will use. They're driven by one thing, generally, price. We are reimbursed. We are reimbursed for contrast. We're not a charity, okay? And when you say, well, we use it in-house, that's a DRG. We don't get paid for the contrast. You don't get paid for doing 10 echoes. You get paid a certain price. So if you do one echo well, that's cost effective. So Val, pick up the charge sheets. Now, outpatient, you're paid to do these procedures and you get money back. We're not losing money, okay? So you really have to fight back from all aspects. And generally, saving lives, cost effectiveness, and reducing patient unnecessary testing is a big one. Now,
One thing that I see is that we don't seem to know all of Medicare's billing codes for contrast. We seem to be like kind of dynamic, but they change literally. They change each year from each year. So
That's
yeah,
right.
so are you posting these someplace?
thank you. The billing codes are in the back on the table by the food.
That's very helpful.
Thanks, Tom.
Because we found out we were underbilling considerably because we were including all of these codes.
He's got a mic right there. Yeah. Just push it up.
Yeah, we found that we were, when we go back and look at, finally, we've found the right person in our hospital that was doing the sending in the billing, and they were sending in like half of these codes. And so it's very important to take this, and make sure your hospital administrators get it to the right people. So when you use contrast, these billing codes are used. We were using about half of the what we could have been reimbursed. We were getting for outpatients. So it's I mean, when you look at this thing, you see there's at least for stress,
Yeah.
there's at least a couple here that almost double the reimbursement.
Linda, can we maybe pass those out to everyone? 'Cause, ICUS put together this cheat sheet. And so Val, this is an important one too. Tom's going to talk about perfusion and CPT codes for that. So let's just start with the basics though. If your echoes need contrast, then you do it and you bill correctly and you sit with your managers. Good question, Val, thanks. Any other questions? We're beginning to loosen up. Thank you. Now people are wanting to talk. Yes.
So for our college patients, we use the clinical support on all of our college patients.
Val, can you give her the mic? Yeah, you use Definity for all your oncology patients.
But we're not able to bill. We're not able to bill strain if we bill for an echo with contrast.
Oh,
My business office makes me
Oh.
remove the strain code. So now we just don't bill for it. And I wanted to know if anybody else was running into that.
whoa. Linda, there's a question. You can't double bill, it looks like, for strain and contrast. I've never heard of that. Tom, comment?
No, I don't know if we were billing for strain.
Yeah, I mean, it's not being reimbursed, but they still want to track it. But so you should still charge it so that they can track its
But
use.
so if you're tracking strain and you bill for contrast, they'll say you get one or the others?
Yeah, they make me remove it. They say
Whoa.
that they're not compatible to be billed together. So I just want to know
Well,
if
that's
anybody
an
else.
excellent-
So I know tracking it is important, but we're not able to do it. So we just stopped doing it probably a year or two ago.
That's very interesting. We need to follow up. That, again, ICAS is really trying to find these issues, solve them. And that's an issue I was totally unaware. We will
Yeah, I've
look
talked to Definity about it, and they can't give me an answer either.
Okay.
These are the strange things you see. Each hospital seems to have some unique misconceptions sometimes. We found our hospital was just clearly had misconceptions. They didn't know they could bill for contrast with stress. But there's a definite, you can see here, there's a definite contrast stress code.
That's really interesting. Again, never heard of that. Now, there is no reimbursement for strain at this time. I think that's what Mahala was saying.
I know that, yeah.
And I wonder, Tom, if we get both, can we bill both? I don't know why not. We bill Doppler, color Doppler. You know what I'm saying? Okay, point made. We'll dig into it. More questions? Oh, great. Let me run through just a couple quick slides. I'm going to leave